Hello and welcome. My name is Raj Persaud and I'm a consultant psychiatrist based in London. And this is Headstarters, a series where we talk to young psychiatrists in training, to work out what it's like to choose psychiatry as a career and the ups and downs of embarking on the training involved in psychiatry. And I'm joined today by two young psychiatrists in training, Ziad and Amy, and we're discussing today this question about whether psychiatrists are proper doctors. Psychiatrists complain that psychiatry is stigmatized, perhaps by the general public, and that their patients suffering from mental illness are stigmatized, but in fact I'd venture to suggest that other doctors stigmatize psychiatrists by not regarding psychiatrists as proper doctors. So what do Amy and Ziad think?
I think it's a sad reality of the medical profession. Before coming on today, I rather foolishly deigned to look online and type in on Google "psychiatrists aren't proper doctors," and I found it quite depressing just how many negative comments came up, just not from the public but from other doctors as well, from a range of specialties: anaesthetics, surgery, medicine, and they varied from the kind of off-the-cuff psychiatrists don't know the medicine jokes to psychiatrists should be stripped of their medical degrees, then at least we'd know where we stand with them. So I think there is an underlying current of stigmatism against psychiatrists in the medical profession, probably by a depressingly large number of other doctors.
I think there probably is. Imagine that when you Google something like that, then you're going to get hits. Whatever you Google is going to come back with people who are of that opinion. And I don't think that it's everybody in the medical profession, but certainly there is an idea that maybe psychiatrists that don't practice kind of medicine like other specialties. And I do think that partly, and this isn't entirely the fault of psychiatrists, but I do think to some degree it is, because I think sometimes when psychiatrists do become de-skilled, and when there are situations where the foundation year doctor is looking after the medical care of psychiatric patients on the ward, and they ask for senior support in that, and they're told, oh, I don't know how to read an ECG, phone the med-reg, then we're not doing ourselves any favours anyway.
I think that comes in with almost every subspecialty in medicine. You know, in the kind of rheumatology clinics, if someone rocks up with a chest infection or something else, they'll say, go see your GP, or, you know, that's not my department. And I think in psychiatry, because we have such a specialist field, and in a sense we're justified in saying that. It's like when you get the call at 3 a.m. from the medreg saying, I've got a psychotic patient, I haven't a clue what to do with them. It's same concept, just in a different field of medicine.
Yeah, that's true. And I guess because we have a lot of psychiatric hospitals are slightly either off-site, or they obviously belong to a different trust than the acute trust. I guess it's much more marked when you're phoning for support, or when you need additional support from the acute trust, then I guess there are almost boundaries between you and the trust, and there's not a clear way to get that medical support. And I guess that kind of propagates the idea that we don't exactly know what we're doing all the time. But I do think that psychiatrists maybe become more de-skilled, or psychiatry, as you become more senior, people tend to be more accepting of the fact that they don't know how to interpret an ECG. And I would have thought most rheumatologists would be able to do that sort of thing.
But what about this point that's been made about the setting in which people practice psychiatry? The two of you, as junior doctors or junior psychiatrists, what about the settings in which you practice psychiatry? Have you been in general hospitals, or have you been in units and clinics that are a bit away from the rest of medicine?
Yeah, come to think of it, since I've switched over to psychiatry, I don't think I've really spent more than half a day in a hospital for any particular reason. Everything is either in its own separate unit, in a separate wing. In Rotherham, for example, it's a whole separate site miles away from the hospital. Even the clinics are kind of out in the middle of nowhere in the sticks in Sheffield.
Yeah, I think the main examples of when I've practiced in an acute trust is obviously in liaison psychiatry, whereas otherwise you're in either a separate hospital or quite distinct grounds in the same sort of hospital site.
So isn't that part of the problem? It's very difficult to be regarded by the other branches of medicine as a proper doctor, inverted commas, when you're practicing very far away from the rest of them.
Yeah, absolutely. And I guess that came, didn't it, when there was a split between the acute trust and mental health trusts, really, that suddenly the two were separated, they're governed separately, and the specialties are somehow considered to be different from each other.
Yeah, well, we don't even get paid by the same people. My friends outside of psychiatry get paid by, for example, the teaching hospitals. I get paid by the health and care trust. So it's just such a split between us and other specialties.
So it sounds like all three of us are agreeing that shouldn't happen.
Yeah, I mean, we have liaison psychiatry for some reason, but I've never heard of liaison neurology or liaison cardiology. We have our own specialty for not being in hospital.
Yeah, but I mean, it's a difficult situation because it's more, there are advantages to being a mental health trust, i.e. that the funding is then ring-fenced for mental health, and even whatever happens with other areas of the acute trust, the funding wouldn't change. So I guess that's the argument for the divide. But certainly it doesn't help the image of psychiatry, I think, amongst medical colleagues.
So have you actually experienced discrimination or prejudice from other doctors? Ziad talked about looking it up on Google, but have you any actual experiences of this?
I think there's a lot of sort of jokes and that sort of thing. Nothing particularly prejudice. There are people that have said, "Oh, there must be something wrong with you to go into psychiatry." Or I remember when I was at medical school, there was one of the medical consultants or something that I was doing my placement with was saying, "Oh no, you're much too good to do psychiatry. I wouldn't bother with that." So I think even from that sort of stage in your career, you're almost indoctrinated with the idea that actually psychiatry maybe is for sort of failing students rather than.
I've had a very similar experience in medical psychiatry. It was kind of just for the slightly weird people who sat in the corner of the lecture theatre dressed in alternative clothing. And even between my friends who aren't in psychiatry, there's a fairly constant ribbing that psychiatry is clearly not a specialty that real doctors go into. But I usually reply that GPs just sit there and give paracetamol to everyone anyway, so it's a bit of give and take.
But what about this other idea that psychiatric research? I mean, most doctors are very naive about the fact there is a body of cutting-edge research going on in psychiatry. They aren't even aware of that, which I found quite astonishing.
I haven't really come across that myself, if I'm honest. Probably because a lot of my contact with other doctors comes through the BMA, and there's fairly regular articles in the BMJ for psych stuff, so I've not come across so much of that myself.
I think that there is a perception. I can't think of any particular incidences where I've been faced with it though, but I think there is a perception that psychiatry isn't as evidence-based as other specialties. And again, I wonder if, given how complex actually the brain is and a lot of psychiatry is, that maybe that is a reflection that actually, compared to other specialties where there are diagnostic tests and that sort of thing, because in psychiatry we don't have that, I wonder if that gives the perception that psychiatry isn't based on as much evidence and it's really a bit more subjective than in other specialties.
Yeah, I think there's something in that, and in a recent argument I had with another friend who's not a psychiatrist, he was saying that, as you were saying, there aren't any hard diagnostic criteria in psychiatry, which I said there were. Just have a look in, at the ICD-10. And we kind of got into the whole, well, with blood pressure, you just pick an arbitrary number, and anyone above that number's got high blood pressure, and anyone below that number's got low blood pressure. Psychiatry is just the same thing, but instead of a number, it's a description which requires some judgment, in the same way that you make a judgment when you're listening to through your stethoscope when you're taking someone's blood pressure. So kind of I've always been in two minds about that argument.
But I do think that psychiatrists tend to be people who are more comfortable with the idea that in order to work out whether someone's hearing voices or not, there isn't a blood test. You have to ask lots of questions, and you have to get a sense of what that other person's experiencing. And that is a slightly more ambiguous experience than reading a blood pressure or seeing a list of blood test results. So it is a bit different, I think, diagnosis in psychiatry compared to the rest of medicine.
Yeah.
But the two of you may not agree with that.
I think it is a bit different because it is more to do with the presenting symptoms rather than any actual sort of clinical sign, or maybe not signs, but any clinical tests or anything like that. And the diagnostic system is based on the sort of clustering of those symptoms to create diagnoses, but there isn't clear evidence in terms of any genetic markers or anything like that for those diagnoses themselves. So I think it is slightly different than some other branches of medicine, but then in lots of other branches of medicine there are also similar diagnoses which are based on presenting symptoms. So there are some similarities and some differences.
Yeah, and I think some of the sort of concepts about the willingness, so to speak, of psychiatry comes from some of the treatments we have as well. I still think a lot of people go, well, you cure patients just by talking to them talking to them for hours in a room. That's not real medicine, and that's not real treatment. And I think people think we sometimes just make it up as we go along, so we have a good excuse to sit and chat.
Well, let's talk a bit about another aspect of this, which is the fact that psychiatrists work with psychologists, social workers, psychotherapists. And I think that the training in medicine brings something different compared to those other specialties and those other trainings. I'm going to land myself in trouble with what I'm about to say. But medicine, you get trained about how to make a high-stakes decision where life and death is at stake. And you get trained in how to arrive at that decision and for it to be a defendable and sensible decision. And you also get trained in how to take responsibility in high-stakes situations. And I think the other specialties, social workers, psychologists, nurses, aren't quite there, and they have an instinctive tendency to turn to doctors in the team and rely on them when the situation gets high stakes and a decision's got to be made. But the two of you may not agree with that.
Oh, that is a dangerous thing to say.
Yeah, I thought it was. Don't feel you have to agree?
No, I've had experience of both sides of the coin. I can definitely recall a few nurses where as soon as anything slightly out of the ordinary happens, the first thing they do is pick up the phone, call the doctor, and want advice. And they are thankfully few and far between. And then sometimes I can recall a few of the nurses, and especially the AMPs and social workers, who, if they're with a less than confident doctor, will quite happily handhold them through, the mental health act assessment or admission or whatever they're doing, and basically do half the doctor's job for them. I think the variety you get with nursing staff, you also get with doctors as well. I'm sure we can all recall the doctor that you absolutely dread seeing on the road to working with you.
Yeah,
Amy, what are your thoughts?
I think that there is some, that there will always be, particularly in any inexperienced staff, that they would look to seniors for support, and I think that's just the nature of it, and I think that's appropriate, really. I guess a lot of the kind of, particularly in liaison psychiatry, a lot of the nurses that I work with are incredible and actually are very able to manage risks as appropriate. But I think there is also an element that part of our work is kind of diluted in other professions kind of taking on our roles, but particularly kind of with nurse prescribers and things like that. There's almost like an idea that maybe we don't need medically trained professionals to work in psychiatry, and I think that's very dangerous idea. I think it's dangerous, obviously, not only for our profession, but actually for patient safety, because certainly I think you need that background in medicine to understand when you're going to be prescribing medication, the full implications of that, the full kind of side effects, how it interacts with other medications. And I don't know whether you can achieve that in a more shorter space of time, and particularly having not worked with other specialties.
Yeah, I think there's definitely some degree of role dilution. I think the junior doctors now are doing fewer ECGs, fewer blood tests, fewer of the traditional, inverted commas, jobs of the doctor, and I think psychiatrists are more becoming team leaders as opposed to team doctors. Whether the two are interchangeable is up for debate.
But I wonder how much of what we're talking about, and we're running out of time a little bit, so we have to think about wrapping up shortly, but how much what we're talking about is something to do with the National Health Service. As I think both of you know, I worked in the National Health Service as a consultant for many, many years, and now working in private practice. And it is interesting that if you go up and down Harley Street where I work, private practice clarifies something, because basically it's what patients are prepared to pay for, and they're clearly prepared to pay for psychiatry. You don't find an enormous number of social workers. You find some psychologists, but not an enormous number. You find a few nurses, but again, not an enormous number. In other words, private practice clarifies that what the patients want is a good psychiatrist, and that's what they want first and foremost. And it's also very interesting, if you walk up and down Harley Street, that I have many orthopedic surgeon colleagues, people in private general practice, who are desperate to find a good psychiatrist to refer to. I took several referrals today from different medical specialties. So in private practice, at least, there's a clear valuation of psychiatry. And I wonder whether part of what we're discussing is the fact that in the NHS, for various reasons, other professions seem to be encroaching on the territory of psychiatry. And private practice kind of clarifies what patients really want.
I think that in part also links into the fact that in the NHS, mental health services are grossly underfunded. We're given less priority than other specialties for the workload that we have. We're given less money for the workload we have. And I think what you're saying about the private practice example probably rings quite true, that in reality there's a greater demand for mental health and a greater need for it than many people are willing to accept. And it drives me around the bend.
But also, I think there is an element that actually doctors and psychiatrists are much more likely to go into private practice than psychiatric nurses, social workers, that sort of thing. You don't really see those people working in private practice anywhere near as much as you do see doctors and psychiatrists.
But my argument is that's because there is no demand. They don't go into it, not because...
It could be a demand issue, or, it could... I guess that you don't work in a multidisciplinary team, do you? Whereas that is how it's set up in the NHS. And it doesn't necessarily mean that either one is better. It just means that perhaps there would be demand if there were psychiatrists working in multidisciplinary teams.
Well,
demand in private practice.
Well, this is where we're all going to have a fight now, I'm afraid. It's inevitable sooner or later. But I think you're making a good point, Amy, but I would have to say the reason why there are no multidisciplinary teams in private practice, not at an outpatient level at any rate, is because there is no demand for it from the patients. Patients do not walk into reception at Harley Street and say, I'd like to see a multidisciplinary team, please. What they say is, I'd like to see a consultant psychiatrist, please.
Yeah,
I think that's something that the NHS finds it very difficult to get its head around.
Yeah, but I don't think people walk into private clinics and say, I'd very much like you to section me and put me on an intensive HDU unit for a few weeks. The kind of patients you see in private practice, and I'm assuming here because I don't do private practice, are more the walking unwell, the people who don't need the intensive input of a multidisciplinary team. They're the kind of people that you could quite happily see in an outpatient clinic once a week or once a month and follow up over a period of time. Whereas obviously the private demand, when someone's acutely unwell and psychotic and everything else, generally falls more into the domain of the NHS. And although there are some private centres, they are of course not on Harley Street. They're miles out from the main city centres where we send our patients when all the beds are full.
I think that's a very good point to make. However, and I remember giving a talk at the Royal College of Psychiatrists about a year ago to a group of trainee doctors who were exploring the conference. It was a one-day conference exploring what other options were available to junior doctors beyond working in the NHS, like there was, work overseas and various other things, research posts and so on. And this was a point they almost made to a man or a woman from the floor when I was talking about private practice. I have to disabuse you and say that in private practice you see seriously psychotic people as well, and you're often able to manage people who you would think need a multidisciplinary team as an individual psychiatrist. So I do think there's a sense in which I suspect in a few years' time we'll come back to be scratching our heads and thinking, what was that whole multidisciplinary team thing about in the first place? Because I don't think teams look after people. I think individuals look after people. And fundamentally it's about caring for people. And I think we're blind to the fact that teams do not do a great job of looking after people. It's individuals that look after people.
I mean, I don't disagree that consistency of care is really, really important, and there are difficulties certainly in the NHS, and actually with how psychiatrists are trained, because obviously that forces patients to see different people every 6 months, every year. There's a big turnaround. But I think also there's an element that firstly it would be preposterous that a single psychiatrist would be able to see a patient like twice a week or more than that in the NHS. There just wouldn't be enough psychiatrists, firstly. There certainly wouldn't be enough money. And the system, I think, of having somebody, a care coordinator, who knows that patient very, very well, I think there are a lot of care coordinators that I've met who are probably more adept in that role than some of the psychiatrists that I've met. So I don't know that it's particularly a psychiatrists are better than care coordinators in managing a patient on an individual level. And I also think that even finances aside, I think that actually there are skills that, just like there are skills that doctors and psychiatrists bring to mental health work, there are skills that nurses and care coordinators bring to that work. And I think a team that is working, a multidisciplinary team that is working well, is financially viable for the NHS, but more than that, it's actually very effective in supporting patients who are very unwell. And I don't know that private practice would be that much more fantastic for all patients, to be honest.
Is there anything you wanted to come in there?
I was just trying to think it through, really, and that's part of the trouble with the NHS is getting those good teams together. I was trying to debate in myself whether that would be any easier in private practice as well, and truthfully I can't really see that happening. I think getting a good team together will be difficult whichever field you're in.
But talking slightly across purposes, I think, because we're debating the fact there's very little money, and therefore what do you do when there's very little money? And I completely accept that if you've got no money, what you end up doing is a certain thing. But that's a completely separate thing to whether that's a good thing to do. In other words, if you had a blank check and you could design any service you like, I still am very doubtful that the amount of times we throw a multidisciplinary team at a set of problems would be a lot less. I come back to my point that I think, what does the patient want? The patient wants usually to see a good psychiatrist, and given the choice, that's what they'd go for. I have also to tell you, and again, I know I'm going to get myself in trouble by saying this, and maybe I've got a biased sample. I see a lot of people, obviously, who come to see me privately, who first of all tried for many years to get treatment in the NHS, and the classic tale of woe is they were seen by a multidisciplinary team, they saw a different worker every few months, that worker was not very skilled, and when I started seeing them and they got better, let's say for the application of a CBT technique to do with hearing voices, that worker was totally dumbstruck or mystified that such a technique even existed. A lot of those workers, and again, I know I'm talking about a bias sample, have very little contact with what's going on at the cutting edge of psychiatric research and so on. And so if you're going to do a multidisciplinary team, the team has to meet frequently, and I do think that the doctor in that team has also got to get a chance to meet the patient. And they very rarely do. Most of the people who end up coming to see me are seeing me because they want to see a doctor, and they just don't get access to that in the NHS.
I think, again, you do have a massively biased sample, because the people that you see are people who are disgruntled and have had a bad experience with the NHS, whereas
That's true.
There are probably plenty of people in the NHS who have a positive experience. And I think you kind of hit the nail on the head, that patients want to see somebody who's skilled and knows their stuff and compassionate. And I don't think that that necessarily needs to be a psychiatrist. I think it can be provided by other staff. And as I say, there are, a lot of the staff that I work with now, and a lot of the stuff that I've worked with in the past, if I was, or one of my family members was in need of mental health services, I would be more than happy for them to see those people, and I think that they would be given an excellent service regardless of the financial implications for that.
Do you think there's also something a bit different about people who end up in psychiatry, because you're both clearly very good at working in teams, I think, and you have a sense in which you're comfortable with that, and maybe a lot of other branches of medicine, people are a little bit more, find that a bit more difficult, and they more clearly, let's say, want to lead the team or be in charge of the team, and I think in psychiatry that's a bit different. Do you think there's a different relationship to teams if you end up as a psychiatrist, in the NHS at least?
I don't know, really. I haven't really thought about that, and I'm not sure that my colleagues in other specialties are particularly any better or worse at team working than psychiatrists. Yeah, I don't know.
Okay, well, one final point is that, and this comes from business and management psychology, there is a lot of stuff, some of it very dubious, about the idea that teams do not naturally work well together, and teams need a lot of help to stay working well together. Do you think that's a bit of an assumption that we make, that teams will naturally work, because often they just basically don't, and we see that, let's say, as far afield as the Premiership in football, to everywhere, that the team does need looking after, and we've talked about the fact that it's a cash-strapped situation in the NHS. Are the teams themselves looked after properly? Because we've talked about the fact that fundamentally it boils down to the patient needs to be cared for by someone, and you're quite right, Amy, they have to be compassionate and skilled, and that doesn't necessarily have to be a psychiatrist. But what about the way the team itself is looked after? Because my experience, again, of teams in the NHS is they felt somewhat battered.
Yeah, I think that there is some truth in that, and I think there are teams that work well together that I've worked in, and teams that are less supportive of each other and less good at kind of working well, and obviously that does have implications for patient care. And I think part of the role of a consultant psychiatrist is to provide some leadership for the team, but also there will be kind of another person, a team manager, whose role it is as well. And I guess if those people who perhaps other team members look to support, whether that's in a formal role like them being a team manager, or whether it's more informally because they're seen as particularly skilled or whatever, then I think that those teams tend to work quite well. I think the teams that tend not to work so well is where there isn't so much hierarchy, so it's a team of people all at a very similar level, and there isn't a clear idea of who to go to for support, and where there are teams where people don't want to ask each other for input and support because they are at a similar level, and that would make them feel like they don't know their stuff, or
my experience with teams so far has been a bit of a coin flip. You either flip heads and you get this wonderful consultant psychiatrist and great team leader who work well together, that inspire this confident, open feeling within the teams, who then work far better because they're able to communicate openly, to the other side where, you know, I flipped tails and had a consultant and team leader who are at loggerheads with each other. You had your clear divide between the doctors and the nurses, and never the twain shall meet. And you get this horrendous team where nothing really quite works as it should do, and obviously the patient suffers as a result. But I think when you get the team that does work, when it does work well, you get something that far surpasses what I think one individual person can do.
Okay, well, we're going to think about wrapping it up very shortly. There may be some other things that both of you may want to say before we close. But if it is the case that psychiatrists are regarded not as proper doctors sometimes, and we talked maybe about the setting is important, I just wondered if both of you had any thoughts about what can be done about that. It feels to me that psychiatrists quite clearly are proper doctors. Amongst other things, we prescribe, and you have to know a fair amount of medicine to prescribe, that the drugs may interact with other drugs the patients are taking, other medical conditions they may have, and also I saw a patient today where I thought there was an endocrinological explanation for the disorder they had. So psychiatry is slap bang in the middle of medicine. Some people have argued it's the last proper medical specialty, actually, for various reasons, in the sense that doctors and sometimes other specialties have become a lot too reliant on technology and have lost track of the whole patient. And some people would say that psychiatrists actually are the very last proper doctors. But I don't know if either of you have a reaction to that.
Yeah, one of the professors in Sheffield often says that psychiatrists are really the super doctors beyond and above all the other specialties, which I think might be pushing it perhaps a little bit far. But I know he's not the only one. I'm pretty sure there's, I hope I got the name right, I think it's Henry Miller, who said that psychiatrists are ideally the superlative physician, in a sense saying that kind of we do encompass everything. We've got the social side, we've got the physical side, we've got you know, the psychosocial aspect of everything else. We kind of cover everything, which I don't think any other specialty does quite the same way that we do.
Amy, what are your thoughts?
I think there's some truth in those points, really, and I guess medicine a couple of hundred years ago was a very different kettle of fish, wasn't it? Where there wasn't actually tests for this, that, and the next thing, and there is some truth that I think in certain medical specialties that a patient becomes kind of a list of test results rather than a person, and the kind of a lot of when you're doing a workup and presenting and that sort of thing, presenting the patient to the consultant, the actual person that you're talking about, it almost gets lost in kind of all the jargon around what blood test results they had, what was on the CT head, and all those things. And obviously those are very important, but so is the person. And I guess in psychiatry, we are we're kind of in a position where we have to rely much more on the patient's story and their kind of life narrative to understand them and to understand their condition, which you don't necessarily get in other aspects of medicine.
Yeah, Dr. Kate Granger, I think, has an awful lot to say about that, and an awful lot of good things to say about that. For those who don't know, she's the doctor who started the Hello, My Name Is campaign to try and treat patients more humanely.
Okay, well, Amy and Ziad, thank you both very much indeed for talking with me today. You have been listening to Headstarters, a series where I, Raj Persaud, talk to young psychiatrists in training. So, Ziad and Amy, thank you very much for the great compassion and skill you've exhibited in putting up with my typical grumpy old man act. Thank you very much indeed.
Thank you.
Thanks.